Hello everyone and welcome to our module on the hand. Let's start by reviewing some important terminology about the hand. You need to know this terminology because in board questions they will often describe a lesion but not show it in a picture. So the thumb is the first digit, the index finger is the second digit, the middle or longest finger is the third digit, the fourth digit is also called the ring finger, and then finally the pinky or small finger is called the fifth digit. When people refer to the volar surface of the hand, they're talking about the palm of the hand. And when they refer to the dorsal surface of the hand, they are talking about the back of the hand. And then finally, in terms of anatomic position, the thumb is lateral and the little finger is medial. If you look at this drawing here of the anatomic position, you see that the thumb is towards the outside, therefore it's lateral. The little finger is towards the middle, therefore it is medial. Let's talk about the bones and joints in the hand. The carpal bones are found in the wrist. I talk about these bones in more detail in the video on the wrist. Then as you move distally, you find the metacarpal bones, the proximal phalanges, the intermediate phalanges, and the distal phalanges. And all of your digits have 3 phalanges except the thumb, which only has 2. The joint between the metacarpals and the proximal phalanges is called the MCP joint for metacarpal phalangeal joint. You then have the first of the interphalangeal joints, which is called the PIP. P stands for proximal interphalangeal joint. And then following that, you have the DIP joint, which is the distal interphalangeal joint. The major nerves that innervate the hand are the ulnar and median nerves. In general, the ulnar nerve innervates structures towards the ulnar bone or little finger. And you can just remember that the L in ulnar is for little finger. The median nerve in general innervates structures towards the radius or the thumb, and you can just remember that the M in median goes with the M in thumb. And if you can just remember this general principle shown in this picture here of the median nerve innervating structures towards the thumb and the ulnar nerve innervating structures towards the little finger, you can answer lots of board questions about nerve lesions in the hand. The muscles that perform hand movement can be divided into those in the forearm, which are called extrinsic hand muscles, and those in the hand itself, which are called intrinsic hand muscles. Let's talk about the intrinsic ones first. So this group includes the thenar group of muscles near the thumb. We'll talk about this group in a second. The hypothenar group near the little finger. The interosseous muscles, which are found between the digits. These are important for abduction and adduction of the fingers. And then finally, the lumbrical muscles, which are important for flexion and extension of the 4 fingers. Let's talk about those groups of intrinsic hand muscles one at a time. We'll begin with the thenar muscles. The thenar muscles are a group of 3 muscles. The 3 muscles are the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. The word pollicis refers to thumb, so these muscles abduct the thumb, flex the thumb, and oppose the thumb. I'll talk about what opposition is in a minute. So all 3 of these muscles are associated with the thumb, and together they form the thenar eminence of your palm. This is a picture highlighting the thenar eminence of your palm. It's the fleshy part of your palm that you can feel if you press on your palm right near the wrist. All of these muscles are innervated by the median nerve, and that should make sense to you based on what we talked about earlier. The median nerve in general innervates structures near the thumb, including the thenar muscles. And this is important in board questions because when there is a median nerve lesion and these muscles lose their innervation, they will atrophy. So atrophy of the thenar muscles is often described in median nerve lesions. This is a picture showing opposition of the thumb. Opposition of the thumb means touching the thumb to the other fingers. This allows for precise movements, and this was thought to be a major step in evolution because it allowed us to carry out more precise and exact movements. Our next group of intrinsic hand muscles are the hypothenar muscles. This is also a group of 3 muscles. The 3 muscles are the opponens digiti minimi, the flexor digiti minimi brevis, and the abductor digiti minimi. All of these muscles move the little finger, and they form the hypothenar eminence of the palm, which is the fleshy portion of the palm highlighted in this picture here. And they are innervated by the ulnar nerve, which should make sense to you because they're on the little finger side of the hand, and they will atrophy in ulnar nerve lesions. The interosseous muscles are found between the bones of the fingers. That's why they're called interosseous. They're responsible for abduction and adduction of the fingers, but not the thumb. The thumb is moved by the thenar muscles that we talked about earlier. There are interosseous muscles on the palmar side of the hand and the dorsal side of the hand. The dorsal interosseous muscles are what perform abduction, and the palmar interosseous muscles are what perform adduction of the digits. And these muscles are all innervated by the ulnar nerve. And our last group of intrinsic hand muscles are the lumbricals, and this is the group that it's most high yield for you to understand because they're responsible for the hand abnormalities that occur in some nerve lesions. So the lumbricals are unusual in that they don't originate from a bone. They originate from tendons of a muscle called the flexor digitorum profundus. This muscle is found in the forearm. It's one of the extrinsic muscles that flexes the fingers. The role of these muscles is to flex at the MCP joints and extend at the interphalangeal joints. So in other words, what you can remember about the lumbricals is that they form an L shape of the hand. This is the L shape of the hand. The metacarpal phalangeal joints are flexed, that's right here, and the interphalangeal joints are straight or extended, that's shown here. So this is what these muscles do. They make your hand form an L shape as shown here. The median two lumbricals are innervated by the ulnar nerve. These are the two muscles near the little finger, and the lateral two lumbricals are innervated by the median nerve. These are the ones near the thumb. If you can remember that the word lumbricals starts with L and that the lumbrical muscles make the fingers form an L shape, then it's easy to remember what happens when the lumbrical muscles lose their innervation. The fingers will take on the shape of clawed fingers. That's shown on the screen here. In clawed fingers, the metacarpal phalangeal joints are extended because they cannot flex, and the interphalangeal joints are flexed because they cannot extend. This is what happens when the lumbricals lose their innervation. It's shown in this picture on the screen here. The MCP joints are extended and the interphalangeal joints are flexed. Now, as we'll see in a minute, if the ulnar nerve has a problem, it will only be the ulnar fingers that are clawed. And if the median nerve has a problem, it will be the median fingers that are clawed. But the point I want to make here is just a general point that the lumbricals make the digits take on that L shape, and when you lose the lumbricals, you get clawed fingers. Now let's talk about the extrinsic hand muscles. These are muscles that move the digits but are found outside of the hand in the forearm. We'll start by talking about the flexors. The extrinsic flexors are found on the underside of the forearm, and one of the most important is the flexor digitorum profundus muscle. This muscle has innervation by both the median and ulnar nerve. Some parts of the muscle are innervated by the median nerve. Those are the parts of the muscle that go towards the thumb. Other parts of the muscle are innervated by the ulnar nerve. Those are the parts that go towards the little finger, the same pattern we've been talking about throughout this video. The role of this muscle and all the flexors is to flex the digits, which means to make a fist like is shown in this picture on the screen here. The lateral two fingers or digits, the ones near the thumb, are controlled by the median nerve. The medial two digits near the little finger are controlled by the ulnar nerve. The extrinsic hand muscles that are extensors of the digits are found at the back of the forearm. The role of these muscles is to straighten the digits. One of the most important is the extensor digitorum. This muscle is innervated by the radial nerve, and it strongly extends the MCP joints. So if you look at this picture on the screen with all the fingers extended, the MCP joints highlighted in green here are controlled by the radial nerve. The interphalangeal joints, when they extend, this is controlled by the lumbricals as we talked about earlier, and the lateral two digits are controlled by the median nerve. That's shown in red here. The medial two digits are controlled by the ulnar nerve. Let's talk about flexion and extension of the wrist because this is important in understanding nerve lesions that affect the hand. The major flexors of the wrist are controlled by the median and ulnar nerves together. There is a muscle called the flexor carpi radialis. This is controlled by the median nerve, and another muscle called the flexor carpi ulnaris. This is controlled by the ulnar nerve, and these muscles work together to flex the wrist as shown in this picture on the left side of the screen. The major extensors of the wrist are all controlled by the radial nerve. It's all these muscles right here. So the only way you lose extension of the wrist and get wrist drop is by losing your radial nerve. And in the video on the brachial plexus, I talk about how wrist drop is a classic finding in a radial nerve lesion for this reason. Wrist deviation is a clinical finding seen in nerve lesions that involve the nerves that innervate the flexor muscles of the wrist. So if you look at this wrist on the screen here, remember that flexion of this wrist is controlled by both the ulnar and median nerves. But the ulnar nerve controls wrist flexors that are closer to the little finger side, and the median nerve controls wrist flexors that are closer to the thumb side. So this means that if you have a median nerve lesion, which means you've lost the ability to flex the wrist towards the thumb side, the hand will become ulnar deviated. This means deviated towards the little finger side. Ulnar deviation of the wrist, especially with flexion, is a classic finding in a median nerve lesion. The opposite is true with an ulnar lesion. So if you have a lesion on the ulnar side, meaning innervation to the wrist flexors on this side are lost, then this means that the radial side muscles innervated by the median nerve will dominate and they will deviate the wrist in this direction. So if you know this, especially for board questions, it's very helpful. In a median nerve lesion and wrist flexion, the wrist will deviate to the ulnar side, and in an ulnar nerve lesion, the wrist will deviate toward the radial side. Now we're ready to discuss the clinical findings that can be seen in median and ulnar nerve lesions. Let's start with the median nerve. So remember what I said, this controls things near the thumb side of the hand. So in a median nerve lesion, there is motor loss near the thumb side of the hand. This includes problem with thumb movements because you lose the thenar muscles. You can also see problems with flexion and extension of the lateral fingers. Those are the fingers closest to the thumb, and this is because of loss of innervation to the lumbricals. In addition, there are sensory findings around the thumb. So around the thenar eminence and the lateral 3.5 fingers, you can see numbness or paresthesias. If you look at this picture on the screen here, everything shown here in brown is controlled by the median nerve. So you can see sensory symptoms here. This includes the thenar eminence. So if you examine a patient with a median nerve lesion, what you may see are the findings shown on this slide. At the thumb, you will see absence of flexion, abduction, and opposition. This is all done by the thenar muscles. Basically, the thumb will be paralyzed. And then in the lateral 2 digits or fingers, the 2 fingers closest to the thumb, there will be loss of innervation to the lumbricals, and this is going to lead to clawed lateral digits like we talked about before. So the patient will have difficulty moving those fingers, and they may take on a clawed appearance. Because of this pattern of weakness seen in median nerve lesions, there is a classic clinical finding called the Pope's blessing. It's also called the hand of benediction. This is shown on the screen here. So remember that patients with a median nerve lesion will have clawed symptoms on the median side of the hand. So these 2 fingers are extended at the MCP and they're slightly bent at the IP joints. That's the classic finding in a median nerve lesion. Now, if you ask the patient to make a fist, then the little finger side works fine and those fingers flex, but the fingers near the thumb cannot do so. So you get this finding on the screen, which is called the Pope's blessing. The thumb and lateral fingers cannot flex, and the MCP remains extended near the thumb side. And you don't have to memorize this finding. Just know that the problem here is that the fingers near the thumb are not moving normally, and that should let you know that it's a median nerve problem. Another finding you'll read about in your textbooks is called the ape hand. This is seen at rest when you examine the hand of a patient with a median nerve lesion. The thumb will be adducted because it cannot move, basically because it's lost its innervation. So it cannot oppose, it cannot abduct, so the thumb will just be stuck against the side. In addition, you'll see thenar atrophy as we talked about before. This is called the ape hand because it's thought that apes do not have opposable thumbs, although in actuality they do. But the point here is it's like you have a primitive hand where the thumb cannot perform opposition. And you don't need to memorize this finding. Just remember that when the thumb is immobile or cannot move normally, that is usually a problem with the median nerve. So let's talk about some of the things that can cause a median nerve lesion. At the wrist level, a laceration of the wrist from trauma can cut the median nerve. In addition, many patients develop the carpal tunnel syndrome, which involves median nerve dysfunction at the level of the wrist. And I talk about this in much more detail in the video on the wrist. When you have a wrist lesion, the flexor muscles in the forearm will be intact, so you won't see any of that wrist deviation we talked about earlier, but you will see all the findings in the hand that we described for median nerve lesions. You can also develop a median nerve lesion if there is an elbow problem. One of the reasons this commonly occurs is because of a supracondylar fracture of the humerus. That's a fracture in the lower part of the humerus right above the elbow. If the median nerve is damaged at this location, you will lose innervation to most of the flexors and pronators in the forearm. For this reason, patients with elbow lesions involving the median nerve have a supinated forearm and flexion is weak. And then as I talked about earlier, a very high yield thing to remember is that in a median nerve lesion that is proximal, like at the elbow, there will be ulnar deviation of the wrist, especially with flexion. This is because the flexor carpi ulnaris muscle maintains its innervation by the ulnar nerve and it can flex the wrist, but when it does so, it pulls it towards the ulnar side. The median nerve gives off a branch in the hand called the recurrent branch of the median nerve. This provides motor innervation to the thenar muscles, those muscles that move the thumb, but it provides no sensory innervation to the hand. This is a very superficial branch of the median nerve. It's near the flexor retinaculum, which is this structure right here. It's a fibrous band on the palm side of the hand that covers the carpal bones and forms the carpal tunnel, which we'll talk about in a minute. So if a patient has a superficial laceration of the hand, sometimes just this branch of the median nerve will be damaged. In this case, the thumb will be immobilized, but sensation will be normal. And you want to remember this for your boards because this is a variant on a median nerve lesion that you may see. Now let's talk about what happens when there is an ulnar nerve lesion. In this case, there is loss of abduction and adduction of the fingers because this is done by the interosseous muscles, which are innervated by the ulnar nerve. So the patient will not be able to fan out their fingers or bring them together. In addition, there's motor loss to the little finger side. This is the little and ring fingers. So the hyperthenar muscles will lose their innervation and you can see atrophy of these muscles, and the median 2 lumbricals will lose their innervation. And then finally, there's also sensory loss to the little finger or ulnar side. If you look at this picture on the screen here, this portion shown in blue on the palmar side and also on the dorsal side is all provided by the ulnar nerve, so you can have sensory symptoms in these areas. So just like the Pope's blessing is a classic finding in a median nerve lesion, the ulnar claw is a classic finding in a patient with an ulnar nerve lesion. This position occurs when the patient has their hand at rest with the fingers straight and not flexed. Because of paralysis of the medial lumbricals, which are the lumbricals closest to the little finger, there will be extension of the MCP joints and flexion at the IP joints, and that will give an appearance like what's shown on the screen here, which is called the ulnar claw. And you don't need to memorize this, just notice that this patient's fingers are at rest and the patient is trying to extend their fingers. The fingers that are not functioning normally are near the little finger side, so therefore this must be an ulnar nerve problem. Ulnar nerve lesions can occur at the wrist level, also from lacerations, just like median nerve lesions. There's also a parallel to the carpal tunnel syndrome called the Guyon canal syndrome, which causes ulnar nerve symptoms at the wrist. And I talk about this in more detail in the video on the wrist. At the elbow level, you can have an ulnar nerve lesion if you have a fracture near the medial epicondyle. This is the medial epicondyle of the humerus, and the ulnar nerve runs right near here. So if you have a lesion here, in addition to all the hand findings, you will lose the wrist flexor, the flexor carpi ulnaris, and as we talked about before, this will lead to radial deviation of the wrist, a very helpful hint in a board question. I'll finish this video by describing the ulnar paradox. You would think that a more proximal lesion of the ulnar nerve, like one at the elbow, would cause clinical findings that are worse than a more distal lesion like one at the wrist, but that is not the case for the ulnar nerve, and this is called the ulnar paradox. So in a proximal or elbow lesion of the ulnar nerve, the ulnar claw may not be seen. In other words, if you ask the patient to extend their hand and rest it on the table, you may not see the ulnar claw like shown in this picture. The hand may just lie flat on the table. The reason for this is because in proximal lesions of the ulnar nerve, you can lose innervation to the flexor digitorum profundus muscle in the forearm, and this muscle has fibers that flex the two little fingers. So when you lose that muscle because of a proximal lesion of the ulnar nerve, you may not see the ulnar claw because flexion at the IP joints will not be present. So what you will see is simply the ulnar digits are paralyzed, but there is no clawing. For this reason, it is said that proximal lesions appear less severe than those at the wrist, and this is called a paradox. And that concludes our video on the hand.